This was the toughest surgery that I've done so far.
Put 5 years of your life into a course, as good as an MBBS. It takes a lot of effort to explain a doctor that he needs surgery. So this story is not only about how he overcome his disorder called dystonia, a person who decided to resign from his job, how he went back to being a doctor and is now actually going forward for his post-graduation. I am here to tell you a story of a doctor who had a tough time finishing his graduation and was really excited about his job, but ultimately had to resign from his job. Do you know what's the reason? The reason is something known as dystonia. Dystonia basically is a neurological condition. It happens in the brain and it causes repetitive contractions of a muscle, making it very difficult for a patient, in our case, a doctor himself, to do fundamental things of daily life, like writing, like cutting his nails, like serving his food. Imagine what this dystonia can do. So this story is not only about how he overcome his disorder called dystonia, but a person who decided to resign from his job, how he went back to being a doctor and is now actually going forward for his post graduation.
So this guy, Dr. Shesha Charan, a young budding doctor, very excited that he's got a future as being a doctor to, impact people and change people's lives, was struggling with his writer's cramp right from his MBBS days. This is the story that he told me. And it was so bad somewhere during halfway through his MBBS that he could not write at all. And he had to use scribe every exam to write on behalf of him to pass his exams. So that's how he passed his MBBS using a scribe.
Hi, I'm Siddharth and I'm working as a ANRS here at PRS Neurosciences. What we are talking about, it's more about the writing. The writing kept making the abnormal movement worsen. So these are some key features how dystonia is usually explained. The kind of dystonia which Dr. Shesha Charan he was going through is called as a focal hand dystonia, task specific. He had a focal involvement of the wrist and the hand and the muscles of the forearm, which was specific to the task of writing. His problem actually started somewhere around 2017 when he was going through his graduation. And I think in the second or third year, when he had to write his exam, it became unbearable for him because he was not able to write for more than 3 to 5 minutes. Pain was severe, and he was seeking some kind of support, as a scribe in the exam. But because there was no physical damage to the brain and there was no physical disability, he won't get a scribe. This doctor, he goes to NIMHANS, he asks for a disability evaluation. They do a disability evaluation and they refer him for therapy, where he is asked to use a board to support the wrist and write. Now, the funny part is the muscles which was pulling the wrist up, which was dystonic, was further strengthened by keeping a board, because when you use a board you tend to extend your wrist, and that actually worsened the dystonic pattern to a point where you could no longer voluntarily. In desperation, he started writing with the left hand. the left hand also started developing abnormal contractions. So he got very, fearful, he got very afraid, and he discontinued writing altogether. Eventually, this abnormal contractions and all started affecting his fundamental doctor skills, like suturing, like using a needle, like writing his documentation. So it was impacting those areas which actually gave him his identity as an individual, as a doctor, as a healthcare professional. And that's when he decided that maybe this profession is not for me, and he discontinued. I will like Sharan sir to explain about how did he get his reference from Excel Care Hospital's medical director, and maybe after that I'll tell you further what happened.
Hi, everybody. My name is Dr. Sharan Srinivasan. I'm a stereotactic and functional neurosurgeon from Bangalore, India. Continuing with the story of Dr. Shesha Charan. So this what happened was, he then went into a job. He was trying to meet some doctors, and he had met some doctors, and it went to an extent that people told him, the doctors counsel his family, that I think you forced him to be a doctor, you have pushed him there. They went to the extent of counseling the family, of even considering him leaving the profession and making him study something else. Can you imagine? Everybody labeled this as psychological, the writer's cramp that he had. It is such a sin. And being a doctor, he himself could not get so much help. Eventually, what happened was, he was working in a private hospital in Bengaluru as a duty doctor. And he told me that if he would write half a page of notes or any consent or anything, for next 3-4 hours, the hand would literally be dysfunctional with a lot of discomfort and pain. He could not even use it for next 3 to 4 hours for writing. So he got frustrated, and he said, what's the point in doing things like this? And one fine day, he went and met the medical director, Dr. Suma, and with a resignation letter deciding that he's going to give up this job without knowing what to do next or whatever to do next. Now, interestingly, I had met Dr. Suma the previous week or maybe 2 weeks prior to what he met, and I had gifted her my book, Rebooting the Brain, where I talk about all of these things. And, surprisingly, within 2 weeks, she had actually gone through the book significantly, especially she had read the chapter on the guitar surgeon, the writer's scribe, the functional neurosurgery that I do for such diseases. She immediately correlated that to his problem, and he said, listen, go to Dr. Sharan. Maybe he can help you. And that is how he came to me, and the rest, as you see in the story, is history.
Sharan sir, he usually, how it works is, when he gets the patient, he analyzes the patient first, and then he refers for a detailed evaluation to me. I do a dystonia evaluation based on the type of the dystonia, and I use specific standard evaluation tools which I have been trained into, so that I can score and check the severity. Along with that, being a therapist myself, and having a background knowledge about how kinematics and biomechanics work, and having a sense of how normally ADLs are performed, because as an occupational therapist, we do a lot of activity analysis, and we understand, how a simple activity can be broken into small pieces and retrained. So that's my skill set. I analyzed his writing pattern. Let me take you to the day when he came for the rehab eval. So we all were sitting in our occupational therapy room here at PRS Neurosciences in Oklipuram. So he walked in. He was just carrying a bag, and because I knew who is he, so right when he was walking in, I was observing his posture, and how was he carrying objects, how was he holding the thing, especially in the right hand. And then he was accompanied by his brother. They both came, and I usually take a detailed history. I ask for a lot of specific parameters. I like to know the chronology of the events, how the worsening happened. So like I told you, his problem started in the right hand. It initially started with a little pain and discomfort. It was more in the the extensor part of the forearm, and then it worsened to dystonia and increase in the difficulty in holding the pen, in writing, gradually started affecting the shoulder, his standing posture at a given point of time, and then it started affecting his left hand as well. I realized it's not just a simple writer's dystonia, which I can finish in a second, and quickly 5-10 minutes of evaluation, around 20-30 minutes of proper detailed history, good videos. Then I can tell him, I can call Sharan sir and tell sir, what, this is a very easy case and we can handle it. Or he may need rehab, he may not need rehab. We have certain techniques through which we are able to pull that, understand that very easily. I realized it's not just a focal and dystonia, and probably it has started spreading proximally and converting into a segmental dystonia at one point of time. After the in-depth evaluation, I called Sharan sir and I told I am seeing one right clear-cut task-specific dystonia in the hand. I am seeing dystonia of the scapula, and I am seeing tremors in the thumb, and he is no longer responding to any sensory tricks. Sir's first question was, "Do you think can you do some rehab for him first before we move for the surgery?" Fact was, it was too severe. The severity of dystonia was too high for rehab management. I also saw a lot of anxiety in him because if you put 5 years of your life into a course as good as an MBBS and you can't practice, I don't see how it can be just managed with only neuro rehab. I very well realized that we need to go for neuromodulation in the situation. But when a doctor, you have to speak to them, they are already well knowledgeable in that area. They understand a lot of nitty-gritties about how the human body system works. But then when I explained him systematically and I showed him some examples of the other patients who have recovered and they are getting back to their life, he was convinced. The next challenge was for him to convince his parents, because his parents were already of the opinion that probably MBBS is not a stream for you. Yes, you put your effort, but probably you need to do something easier in life. He got his parents, his mother and father came. For a mother, like a child undergoing surgery is a huge stuff. In the OPD, I had to speak to them, sit with them. As much time I had spent with Shesha Charan explaining about what is this problem and why as an OT I may not be able to contribute and I need some additional interventions to happen for him. It took the similar amount of time to explain the caregiver. So my one small message, what I want to give here is, it's not just about speaking to the patients and explaining them their problem. The caregivers need a different approach, because Dr. Shesha Charan, he was physically experiencing it and his mother was emotionally experiencing it. These are two different worlds. So usually we have a habit that Sharan sir and myself, we will discuss in the morning once, that okay, what are the problems I've identified, are we addressing all of them. So in that process, either me or Sharan sir, one of us will call each other. That day I happened to call Sharan sir and I told him, sir, okay, we are scheduling this surgery scheduled today, and he has dystonia of the proximal segment and the distal segment, and there is tremors. So though Sharan sir, he had planned his surgery like every surgeon does, based on our discussion, we realized that this, Dr. Shesha Charan, he needs a slight modification in the surgery. Plus, there was a requirement of additional intraoperative monitoring, which I personally had never done before this case. So when we sat together, one was on the phone call. We had a detailed discussion of what all things are we going to work on, what all problems are resolvable, what problems may be persisting, and what targets will be selected. So I was excited because first time I was going to see with each lesion what kind of problem is getting resolved.
But when we evaluated as a team, this guy, he did not have a simple writer's cramp. He had tremor of his right thumb when he used to play on the joystick of the, what you call the video games. He had the writer's cramp. He had pain in the hand. He also had some shoulder dystonia. There was a lot of different phenomenology going on from his perspective. It was not a straightforward writer's cramp. So the question right now was, there's not one target to solve all these problems because each of them are different circuits that is firing. So the question we had to strategize to see what was the minimum number of, lesioning that we had to do to get the maximum benefit. That's where the flexibility comes in because of the kind of equipments we have, the kind of training I had in Japan with the world's best surgeon for especially lesioning called Professor Tako Metaira. And having done hundreds of surgeries, it gave me the confidence of being a challenging case and how it has to be done. So as you see in this picture here, we put a plan, Siddharth and me, where, this 3-hole holder, different nuclear possible targets we have to get. So we had to target the VO nucleus, the ventralis oralis nucleus of the thalamus for the writer's cramp. We had to target the VIM nucleus, the ventralis intermedius nucleus of the motor thalamus for the thumb tremor. And at the same time, I had to target the paradothalamic tract or the GPI for the proximal dystonia that he had. Different things. So when I actually mapped and looked around, the PTT, the VU and the VIM are in like a small arc very close to each other. But still we had to target them. See, in that area of the brain, 9-10 centimeters deep inside, we call it deep brain area. 1 millimeter is like 1 kilometer. It's like this. 1 inch makes a lot of difference when you put food in your mouth or food in your nose. So I decided, let me target the tremor first before I go into the dystonia. So you see the 3-hole holder, the picture that you're seeing online. The 3-hole holder, when it's aligned correctly, from the center is 1.25 millimeters from each line. So we call it the anterior, central, and posterior trajectory when we plan a target. So the posterior trajectory of the VO coincided very close to the anterior trajectory of the VIM because the VIM nucleus is behind the VU. So we strategized in such a way that I decided to do the posterior VO anterior VIM overlap as the first target to see what happens to this. And with that plan, when I did that, lo and behold, the tremor stopped completely. So we knew we were bang on. That's the first target done. The strategy was right. Next strategy I had is because he has a writer's cramp, we will do the 2 lesions of the VO to make sure the writer's cramp went. So as we started doing the 3 lesions of those 2 trajectories, the writer's cramp started improving. But the proximal dystonia still persisted because proximal is a different circuit. Then we did the PTT, the lateral PTT, PTT2, and the dystonia got better. So it was like an arc. And this is very difficult to get even if you do a DBS because you can't get a lesion in that shape, but that's what happened. This was the toughest surgery that I've done so far in movement disorders lesioning. And we had to do 9 lesions, in different strategies. And this guy, in intense rehab after that for 2 months, which Siddharth will continue to talk to you, made near total recovery of his symptoms. He's so excited. He's looking for a PG course now and fully back as a doctor.
Like, Sharan sir, in his video, he has told that, how he planned the surgery targeting each and every problem. I had to make sure that as a rehab professional, with each lesion in each location, what symptoms are getting resolved and how will I qualitatively or quantitatively make sure that I have documented it. So I could clearly see how the problems were getting resolved. I saw the tremors settling down, the tremors he had in the thumb, that settled down. I saw the dystonic component of the shoulder and the scapula settling down. I saw the dystonic component of the thumb and the finger settling down. The only point towards the end of the surgery where me and Sharan sir, we both were a little dicey was he was still having some amount of movement of the wrist which was pulling up. So it took a good 3 to 5 minutes of discussion for both of us to decide if it is residual dystonia or is it a maladaptive muscle memory. Let me tell just a quick thing about muscle memory. Imagine you are eating food and you're watching TV. Do you have to think about every spoon you take to your mouth, or are you able to enjoy your TV and simply eat food? That simply eating food is basically a motor schema which is saved in your brain. You don't have to think each and every time how you are going to pick up the food and eat, right? Imagine this holding position because of a problem like dystonia gets disturbed, meaning instead of taking like this, your hand is going like this. Okay, now even after the surgery, this learning what has happened has to be corrected, and it is difficult. It takes time, it needs patience, right? So there are three currencies which I tell all the patients who are going through rehab for dystonia, either before the surgery or after the surgery, which they need to spend. First is time, second is patience, and third is money. Okay, you may have the money, but if you don't have time and patience, the outcomes will be suboptimal. Dr. Shesha Charan had all three of them, and he used them wisely when we were doing the rehab post-operatively. Post-op after the surgery, usually again, because I have done the pre-op evaluation, I have seen what changes are happening intraoperatively. We have taken good videos, so only I can find out what's happening post-operative. Now I go for, usually I allow the patients to take rest for a day because the screws are fixed and there is edema, there is pain, sometimes there's a little oozing. So they are not in the right space to be evaluated. So usually one day good rest allows them to recover from the stress for the surgery. On the day 2 when I went and I met him, he was very happy despite having the pain and the swelling in the head. He told me, "Sir, I have resigned from that job, but I think now I have enough time to go through the recovery. You tell me how many days I have to come to you." So I thought, okay, now this is an ideal situation because usually wherever I have done dystonia rehab before, they all are in a rush. They don't have enough time to give to the process, and so I have to make the plan in a very tailored way and cut all the extra edges. I cannot go and verify any other additional therapy technique or outcomes and measure and say that yes, certain other techniques are also useful. So when I went, I did the post-op evaluation. We did the same writer's cramp evaluation and the dystonia evaluation, the standard evaluation tools, which we did in the pre-operative phase. Post-operatively, when I did, this guy picks up the pen, but wrist is moving up again and again, right? And his mother was there, and she was upset. The hand is again moving against her. Surgery has not come out well, and there was a lot of conversation. It took a lot of time and effort to calm her down and explain about the muscle memory to her again. Then I use a simple trick usually to differentiate the muscle memory from the dystonia. So what we do is, when we take a pen, we just take a rubber band and anchor it against the wrist. So the idea is, because a dystonia problem in itself is sensory motor in nature, if I can give certain sensory direction to the pen, right, through the pull, I anticipate the muscle memory to rectify for that moment when she is writing. The moment I put that rubber band, he wrote normally. He wrote, the alphabets came out very clearly. And both the mother and Dr. Shesha Charan, they were surprised because it's magical sometimes to see that. Okay, so there are many tricks like that, which we can differentiate between the dystonic element and the muscle memory aspect. Now I had these three sheets. One, I have the sheet from the pre-op evaluation where we have made him write. I had the intra-op and I had the post-op. And in the post-op, I have the with the adaptation, the rubber band, and without the adaptation. When I showed those papers to Sharan sir, he was surprised because the severity of dystonia and the outcome what we got, they were completely disconnected. We were anticipating it will take a lot of time for him to just learn how to hold the pen again, slowly, recover through it. So that gave me a hint. Probably Dr. Shesha Charan is going through a different recovery path, mostly because of how the neuromodulation surgery was planned and how the problems were targeted specifically. So I also thought, okay, let's see how fast can we push the rehab this time, because usually I take it a little slow based on the endurance, based on the the fatigue, the physical fatigue and the mental fatigue. But this time, because it was a doctor and he was in a rush, he has to go back to his work. So he said, no, I'm ready to give my 100% into it. I want my writing ability back. So we started with rehab. It's like, the rehab for writer dystonia post-op is like teaching a child in a prep or a KG how to hold a pencil again, like penmanship, what we call, how to hold a pencil again, how to place the pencil properly, and start with basic curves, basic patterns of writing. So I started. For the first week, it was slow. Doctor was also feeling a little disappointed about how the recovery is happening, and then sudden magic happened. This guy, he comes and tells me, sir, yesterday I have written one page in 10 minutes. Look at my handwriting. His handwriting was not bad at all, to be honest. It was legible. I was able to read. And he said, I did not need any kind of rest in between. I wrote it. After writing, I felt a little, inattentive, and I required some good sleep. But this long, I have not been able to write this long ever since I have been diagnosed with dystonia. So that gave me a hint. It gave me a hint as to how I can plan the needs or the goals for the rehab better. Usually what happens now when we say that we want to work on the writing or we want to work on the strength part, we focus only on the writing or the strength part. We are not looking in which all context the person has to write. For example, if I look for Dr. Shesha Charan, he had to write sitting, he had to write in standing position, he has to write in walking. He has to write with his notebook on a table, he has to write with his notebook on his lap, and a notebook in his hand, right? So because as a doctor, it's not always necessary you will get a good surface to write and comfortably sit and do all that. Patient can be anywhere. You may be in the community, you may be in the OPD, you may be writing notes in the rounds, you may be with a senior doctor, and while walking you have to make the notes. So that context came in, right? The performance context and the performance areas. When we see, we looking at writing definitely, but he also told he has problem with clipping nails. He has problem with opening the cap of the bottle sometimes. Okay, and sometimes when he's serving food, when he's eating, the fingers are not they are not approximated properly. They are like in some awkward position. So I said, okay, let's make something known as an activity grid. A grid is like, it's just like a puzzle, and you're putting all the pieces together, and you keep ticking what all have you achieved to what level of efficiency. It took a solid 2 to 3 months to get him to write not only in sitting but in standing, in walking, with support, without support. We actually made him write in a notebook to actually analyze how his writing was getting better. We looked for time, we looked for the number of lines he was writing, we looked for the legibility of writing, we looked for the pain and fatigue. So specific metrics were measured, and I am proud to say that started with say 5 lines, and it took 10 minutes to him. He went to writing 2 pages in 5 minutes. So that was a huge recovery. Apart from that, because once I saw, and I had my judgment as a therapist, that he's achieving his goal sooner than what I've seen in other patients who I've dealt with before. I asked me, doctor, what other things do you want me to train you in? Because writing is something which I think you are mastering it really fast. He said, I wanted to learn suturing again. The interesting thing, ever since he started developing dystonia, he could never suture. Imagine a doctor not being able to suture. And he was having a lot of trouble, because see what happens is when you have to suture, there's a scissor kind of equipment, and you hold the the needle at the tip. So whenever he sutures, his thumb will push the scissor and the needle will fall away. So that's the dystonia what I'm trying to tell you, and it's very dangerous for someone who is not able to control the thumb and suture. So I had to learn some things about suturing. So he told how to take a nib, how to tie a knot, and you cannot hold the needle because it's a sterile procedure. So how to move and pull and push. So those specific movements he showed us. I saw some videos. Then we did analysis of that, same activity analysis. We understood what all movements are getting affected. So the movements were more when he was in mid-prone, wrist getting extended, thumb moving out. So we started correcting that. Another 2 to 3 weeks, believe me, he started suturing. He started suturing and sitting and standing, both the positions. And he said, you know what, if I'm able to make this simple suture, I can actually do, a lot of my work. It's very easy for me now. So that was very gratifying. I was able to guide a doctor and help him go back to his job. So that was the, I really felt I've contributed something back to the medical fraternity and to the healthcare profession. Then the time came when I had to hand over this patient now to one of my colleagues. Her name is Abhirami. She is an occupational therapist, and I had to understand, because I have gone through this entire journey, and it's very, it's a lot of brainstorming had happened. So how do I concise all this information in a way that so that my colleague can do the same quality of therapy or same deliver the same outcome as to what I would have done for Dr. Shesha Charan. So I showed her all the documents, what all documents and how the evaluation was done. I took her from one video to another and showed her what all problems I identified initially, right? How we were seeing the changes, what were happening within the surgery, and what all changes I have seen after the surgery. It is impossible to do this if you don't have a good documentation for your patient, which means you need to select the right place and time to evaluate. You need to have a structured evaluation form. Let it be your own evaluation form or standard evaluations which the movement disorder communities they suggest. You need to have the skill set of making good videos, capturing exactly what you want to show, and then organize them. You cannot keep the videos haphazard and one fine day think about which video meant what. So that's one skill set which I've learned working in the movement disorder team here at PRS Neuroscience. I handholded my colleague for some time because it was the first time for her, but then I saw her expertise in the field of retraining skills. As OTs, we are really skilled in that, and I appreciate her for the the outcome she has produced. She trained Dr. Shesha Charan to a point where we had a simulated clinic for him here at our center. He was a doctor and we were his patients. We wanted to know under pressure when Dr. Shesha Charan goes back to his clinic or joins a hospital or does his post graduation, will he have trouble in riding or not? So that was the ultimate question. And we were very happy and we are proud to say that he cleared that test smoothly. Our work evaluation came out stating that he has no problem while writing, and I think we achieved our goals to the 100%, to the point. Like he went satisfied out of our institute. Sharan sir, he was satisfied with the results. I was satisfied as a therapist, and we were very proudly talking about this in all our international communities and conferences.
So, guys, remember the first message is There is a lot of help available. If A cannot help you go to B or C or D, please keep seeking. That's what our scriptures say. Ask and thou shalt get, seek and thou shalt find. But that's what it is. Make sure that's the way you look at it. Don't give up. Never ever give up. So much is possible in functional neurosurgery. If we come to the right doctor, the right diagnosis is done, the right circuits are checked, the right strategies for the OT is used, right techniques are used during surgery, right feedback is watched during surgery, and right interpretation of what has happened during surgery. If you do all of this, followed by the right rehabilitation by a movement disorder trained therapist, magic can happen. All the best to you.
If I want to concise what has happened, in this journey, first and foremost, identification of the problem. Dr. Shesha Charan for a long time was believing that he has an orthopedic problem, not a neurological problem. So the doctors, when he was first diagnosed with dystonia, it gave him some confidence that there is an intervention possible. Second, identifying the right doctor who can treat you and the right therapist who may have the skill sets to treat you. It's very important to go and ask, have you seen a patient like me? Have you treated a patient like me? What are the outcomes? And understand it enough so that you believe in the process. Third point, once you have decided that I want to take this step as a patient who wants to take the treatment, it also becomes some part of your responsibility to convince your family that you are ready for it. That's the third learning point from the story. Fourth, the devil is in the details. The more specific you are in your evaluations, in your management, in explaining the caregivers and the patient about problems you have identified and the goals you have settled for and the management and the outcomes you're looking for, keeping in mind the probability of achieving that goal. Like in this surgery, we never say 100%. We only promise around 30 to 40%, and rest we leave to the patient outcomes and his recovery, how it is happening. Putting that systematically is very important. Fifth, good communication between the professionals in the team, having hope in disorders like dystonia, because there is no evidence to say that you have a problem, but having the hope that if you keep pushing and keep searching for doctors or rehab professionals or other patients who have gone through this journey, you can also find your solution. So don't lose hope. Feel free to reach our team. We have many other patients who have gone through a similar journey, who have successfully gone back to their life. So all I want to say is give us opportunity to serve you so that we can make your life better.
I'm Shesha Charan. I'm MBBS doctor by profession. I had writer's cramp. Initially started in my second year of MBBS in 2017. Initially it was I observed the slowness of writing. Then my hand started to cramp. Eventually around 2018 or 2019 it spread to my forearm and to my shoulders. In 2019 it was diagnosed as writer's cramp in the hands. Took a scribe to clear my exams and cleared it using the scribe. After that, continued on, but dystonia which was there, it started to affect other tasks also, which were like other than writing, like typing and cutting nails and all. I had problems with cutting my toenails, and after some time, it even spread to my left hand, mirroring the movements in writing and typing. And in around 2022-2023, worsened. I couldn't even write 5 to 6 lines without cramps. I met Sharan sir in October of 2024. Then he suggested vivothalamotomy. Then I Siddharth sir and thus they did an evaluation and told me to go to Sanjeev sir to confirm the disease and all. And after that, I was posted post surgery on November 14th. The surgery was done, and after that, got discharged in 3 to 4 days. After that, it was then again I had to come to rehab. Initially, I couldn't. I could write about 1 to 2 lines, but After the surgery, the dystonia had gone, but they had to retrain my muscles so as to remove the dystonic muscle memory. For that, I had to come to rehab. Initially, I would write around 1 to 2 lines. They tied a rubber band to my hand and then did some traction training and all. That one for around 3 to 4 days. After that, it was better. So gradually picked up writing around 5 to 10 lines in 10 minutes, and it's gradually improved. Now I can write about 1.5 pages in 20 minutes. And initially, the writing part was difficult. I used to grip the pen too tightly. Writing was not legible and all. But gradually, Siddharth sir and other therapists, they helped in doing it. And post-operatively, even physiotherapy was required because of some loss of balance which came after the surgery. That got corrected in 2 to 3 weeks from physiotherapy. Now the problems which I had are almost gone. I'm able to write properly. Even typing, there's no problem. In cutting on the nails, there's no problem. It's fine.
So I had a personal question. I know as MBBS graduates, as doctors, you would have put in so many years of work, and Sharan sir told me you'd almost want to quit your job because of the issue. So that must have been a difficult phase where you had to give up your career because of this.
That's true. Recently joined for less than 1 month and joined the job there. Couldn't continue it. Medical director of the hospital, she was Sharan Srinivasan junior. She also recommended me to meet sir. The occupational therapist and physiotherapist, they are doing a very good job here.
Thank you, sir.
2017 ಇಂದ ಇದಾಗಿತ್ತು. when he was in second day MBBS. ಆವಾಗ ಅಷ್ಟು ಇರಲಿಲ್ಲ. ನೆಕ್ಸ್ಟ್ ಥರ್ಡ್ ಇಯರ್ ಇದು ಮಾಡಿದಾಗ ಸ್ವಲ್ಪ ಪ್ರಾಬ್ಲಮ್ ಇತ್ತು. ಹೆಂಗೆ ಏನು ಮ್ಯಾನೇಜ್ ಮಾಡ್ಕೊಂಡ. ಫೋರ್ತ್ ಇಯರ್ ಅಂತೂ ಕಂಪ್ಲೀಟ್ ಆಗಲಿಲ್ಲ ಅವನಿಗೆ. ಸೊ ಸ್ಕ್ರೈಬ್ ತೊಗೊಂಡು ಅವನು ಆಮೇಲೆ ಎಕ್ಸಾಮ್ ಇದು ಮಾಡಿ ಕ್ಲಿಯರ್ ಮಾಡ್ಕೊಂಡು ಆದಮೇಲೆ 1 ಇಯರ್ ಇದು ರೂರಲ್ ಸರ್ವಿಸ್ ಆಯಿತು, ಅದಾಯಿತು. ಮತ್ತೆ ಬೆಂಗಳೂರಿಗೆ ಬಂದ ಇಲ್ಲಿ ಎಕ್ಸೆಲ್ ಕೇರ್ ಅಲ್ಲಿ ಜಾಯಿನ್ ಆದ. ಜಾಯಿನ್ ಆದಾಗ ಅವರು ಅಲ್ಲಿ ಸ್ವಲ್ಪ ಬರೆಯೋಕ್ಕಾಗ್ತಿಲ್ಲ ಮೇಡಮ್, ಹಾಗೆ ಹೀಗೆ ಡಾಕ್ಟರ್ MD ಇದಾರಲ್ಲ ಅವ್ರು ಸಜೆಸ್ಟ್ ಮಾಡೋದು, ಇವ್ರನ್ನ ಶರಣ್ ಸರ್ನ ಮೀಟ್ ಮಾಡಿ ಅಂತ ಅಂದ್ಕೊಂಡು. ಸೊ ಮೀಟ್ ಮಾಡಿದ್ಮೇಲೆ ಇಲ್ಲಿ ಎವಾಲ್ಯೂಷನ್ ಮಾಡಿ ಅವನಿಗೂ ಏನೋ ಹೋಪ್ ಸಿಕ್ತು. ಸೊ ಇವಿಗೆ ಗೆಟ್ ಅಂದ್ಕೊಂಡು ಅದಕ್ಕೆ ಮುಂಚೆ ಅಂತ ಸ್ವಲ್ಪ ತುಂಬ ಡಿಪ್ರೆಸ್ಸಲ್ಲೇ ಇದ್ದ ಅವನು. ನೆಕ್ಸ್ಟ್ ಏನಾಗುತ್ತೆ ಏನೋ ಅಂತ ಅಂದ್ಕೊಂಡು. ಸೊ ಈಗ ಅವನು ಫುಲ್ ಕಾನ್ಫಿಡೆಂಟ್ ಅಲ್ಲಿ ಇದ್ದಾನೆ.
ನಾನು ಅದಕ್ಕೆ ಕೇಳಿದೆ ಅವ್ರಿಗೆ, ಬಿಕಾಸ್ MBBS ಓದಿ ಡಾಕ್ಟರ್ ಆಗೋದು ಇಟ್ಸ್ ಅ ಡ್ರೀಮ್. ಡಾಕ್ಟರ್ ಆದ್ಮೇಲೆ ಇವಾಗ ಇಫ್ ಯು ಹ್ಯಾವ್ ಟು ಗಿವ್ ಅಪ್ ಯುವರ್ ಕರಿಯರ್, ಈ ಪ್ರಾಬ್ಲಮ್ ಇಂದ ಸ್ವಲ್ಪ ಕಷ್ಟ ಆಗಿರುತ್ತಲ್ಲ ಅವ್ರಿಗೂ. ಕರೆಕ್ಟ್.
ಸೊ ನೌ ಹಿ ಈಸ್ ಕಾನ್ಫಿಡೆಂಟ್, ಹಿ ಕ್ಯಾನ್ ಡು MD ಅನ್ಕೊಂಡು ಈಗ ಇದು ಮಾಡ್ತಾ ಇದ್ದಾನೆ.
ಇಟ್ಸ್ ವೆರಿ ನೈಸ್. ಸರ್, ಇಲ್ಲಿ ಫಿಸಿಯೋಥೆರಪಿ ಇರ್ಬೋದು, ಇದು ಅದರಿಂದ ಅವ್ರಿಗೆ ಹೆಲ್ಪ್ ಆಗಿದೆ ಅಂತ ನಿಮ್ಗೆ ಅನಿಸ್ತಿದೆಯಾ? ಆರ್ ಹೌ ಡಿಡ್ ಯು ಲೈಕ್ ದ ಫಿಸಿಯೋಥೆರಪಿ ಪಾರ್ಟ್ ಆಫ್ ಇಟ್?
ತುಂಬ ಚೆನ್ನಾಗಿ ಹೆಲ್ಪ್ ಆಗಿದೆ ಅವನಿಗೆ. ಥ್ಯಾಂಕ್ಸ್ ಟು ಶರಣ್ ಸರ್.
ಥ್ಯಾಂಕ್ ಯು
ವೆರಿ ಮಚ್.
ಥ್ಯಾಂಕ್ ಯು ಸರ್.
And those who have cooperated for him to get well, even occupational therapist and physiotherapist, and another thing is Mr. Siddharth. Even he also made him to get well soon.
Thank you, sir.